So like I have said, this is a very important topic in terms of health financing. And when you do domestic financing, there are usually 5 areas, and I'm going to hear from the experts here how they are going to articulate this. Financing can come from the fiscus, that means from your government. It can come from special taxes. Some people have put on taxes for cancer, taxes for whatever. It can come from donors and partners, including from Donald Trump. It can come from the private sector. It can also come
that is not sustainable. Everything has to be locally owned. We have learned from COVID-19 and many other epidemics how strong localized community-led identifying the responses and implementing the responses in a way that is supported by government and also by resources being available for them to do the responses and to provide the services. We have great examples from South Africa, from Cote d'Ivoire, from Malawi, and from other regions, where, for instance, in Malawi, 1 million US dollars was set aside and provided to communities to do community-led monitoring. We have Cote d'Ivoire also contracting civil society to provide HIV testing services as well as case management. So there are areas where things are working when communities are financed, supported, and are able to deliver. The most important things is that they have to be part of the solution, part of the planning, part of the conversation. In terms of localization, again, for it to succeed, it has to be planned, it has to be financed, it needs institutionalization, it needs frameworks and policies that are supporting civil society. You cannot criminalize civil society, and then also expect them to be part of the solution. It has to be a conducive environment for civil society to be able to operate. It requires joint planning between government and communities. We can't plan one end and in another end call on the support. We have to plan together. We have the frameworks. We need to make sure that the procurement services are supportive of civil society to be part of this solution. In terms of some of the innovations that we have seen in Africa, we have seen where social enterprises can bridge the sustainability gap between donor cycles as well as the national systems, especially for services that require agility and proximity. One of the key things that we have known and we have seen is that communities have done a lot of innovations. They have looked at creating some of the responses at their local level. Some of the innovations that we're talking about are community pharmacies. So people are able to access medicines and other things at a local level within walking distance. So community pharmacies have been very important. Diagnostic kiosks where people are able to go and get diagnostics and be diagnosed with some of the diseases and therefore respond to that effectively. Peer-led social enterprises reinvesting the revenue that they have mobilized in prevention and other healthcare. We have seen women and youth-led cooperatives producing health commodities that are able to be facilitated and delivered within the services, and also making sure that the underserved areas are covered. What's needed in terms of the support for resilience? Because we cannot just talk about community-led programs without looking at what kind of support systems are needed, because once we do that, then it becomes just another rhetoric. So we need to make sure that there is catalytic financing that supports and that is able to fund the work that is done by communities. We need to make sure that there's blended grants that are available, investment capital that is available. That's why it has to be institutionalized, and also making sure that there are frameworks and policies that are supporting this process. What we are trying to do and what we are trying to advocate for is that it is an institutionalized process that is not just viewed as a project or as a quick response. It has to be something that is sustained. In terms of some of the successes, in terms of the localization, it has to be sustainable finance, as we have already established. That domestic, predictable, and diversified financing is quite important. The resources cannot just come from one revenue. It has to come from different revenues. And also, we know that when we integrate community-led organization and community-based organization to provide services. We ensure that they are part of the schemes, they are part of the, particularly when we are talking about insurance schemes, they are part of that. They can't be external and outside. They have to be part of what the government is doing, what the private sector is doing, and whatever schemes that are being developed. We know that in many countries there are insurance schemes. We need community-led responses to be part of those insurance schemes. We also need a couple of things. We need the donor partners to be part of this solution. They have to be part of sustaining this, one, by providing co-financing and matching the domestic investment. Also by incentivizing implementation of the programs and the procurement services. We need frameworks, policies that support community-led responses, community financing, and advocacy capacity. Innovation and sustainable domestic funding, we have seen a couple of those in different countries. We have seen in Kenya, a TICO platform that has really developed impact bond with the government of Kenya and working in collaboration with CEF, which is a private sector foundation, working with different partners to ensure that adolescent girls are having access to services that prevent pregnancy, but also ensuring that they are having access to HIV treatment at a very early age when they need that. In terms of South Africa as well, we have seen the social impact bond, which is led by NACOSA and other partners. Again, targeting the fact that supporting the adolescent girls and young women to access PrEP, but also to stay in terms of adherence to ARTs. That has been quite important we've seen that in terms of the countries and the successes therefore, and there's a lot that we can learn from the different countries. In terms of the stakeholders, there's a need for alignment. We can't have government having issues and focusing on certain things and then the communities focus. There has to be an alignment in terms of identification of the priorities, alignment in terms of shared investment, alignment in terms of the key priorities that the countries want to focus on. We do need donors to support us in terms of de-risking the localization, because there's always risk associated with localization. However, we need donors to also lower their risk and see how to support localization as an agenda. We also have to work with the government in terms of formalizing the role of communities within the health architecture. It can't be a situation where we say, where the government is not reaching people, then the civil society and communities will reach the underserved community. It has to be a planned and a supported investment. We have to make sure that there's meaningful engagement of communities. We also have to make sure that they are part of the conversation. They are not called in the room after decisions have been made. And in order to do that, we need to make sure that there's a facilitation of the conversation as well as the policies that are supportive of the engagement. GNP Plus worked on a comparative analysis, which also gives us an idea of where things are working and where we need to support more. In terms of social contracting, as a powerful sustainability strategy, as much as I have been reinforcing the fact that we need government support, we need civil society engagement for service delivery, and also we need to make sure that there are resources available. We've had Namibia, Tanzania, Zambia, and Zimbabwe. They are moving forward with the social contracting. However, We have Kenya and Malawi that are catching up as well. So in some regions, in some countries, things are working well and we can take lessons from there. But also in some countries, they are still catching up, and therefore a South-to-South collaboration will be needed. We need to coordinate advocacy and policy development to standardize social contracting and ensure sustainable HIV financing across the region. So whatever we make work in the different countries, we need to make sure that we share. In terms of the sustainable response, for us to sustain HIV and health-related responses in Africa, we need to be locally led. It can't come from anywhere else. It has to come from us. It has to come from our communities. We need financial sustainability. We know that some of our countries are recovering from COVID-19 impact. However, we do need increased domestic resource allocation to health, and specifically targeted line item budgets that are focusing on supporting the civil society and communities to implement the program. We need to make sure that there are systems that are integrated, that are community-led, that are embedded in the broader universal health coverage and health governance framework. It can't be, we won't succeed if we are not organized in that way. We need to shift, colleagues. We need to shift from project. When we're thinking about community-led programs, we think small projects. These are the communities that are really going to be changing the architecture of health. They are going to ensure the services are provided to communities, and therefore we need to make sure that they are part of the health systems. Ultimately, we need to make sure that there's investment in local innovation. It can't be innovations that are coming from somewhere else. There are innovation, there is creativity in terms of solving our problems, and therefore we need to make sure that we are supporting local innovation. Lastly, thank you so much for spending these few minutes with me. I look forward to hearing from you about some of your innovations, about some of the solutions that you provide in your community, but also your experiences in terms of financing some of these responses. And we can share about that and also learn from each other, because that is important. Also, if there are frameworks that are set up in different countries, we need to learn about that as well. Like I said, I'm coming from the Global Fund Replenishment Pledge Summit, and the challenge is that the resources are declining, and therefore how do we maximize the resources that we have? How do we maximize the innovations that we have? How do we make sure that the community receive accessible, affordable, and qualitative health services? Thank you so much.
Thank you so much, Linda. I think that we hold our questions and comments until we hear from Dr. Fall, who is online. He's a well-known epidemiologist and an expert in public health, emergency response, and also health diplomacy. This is a new discipline, health diplomacy. People are really going into health diplomacy. He used to work for the WHO as an assistant general manager. Now, he was born in Dakar, Senegal, and currently is the CEO of Institute Pasteur in Dakar. Let's hear, where is the technician who was going to, where is the young man who was going, where are you?
Good morning, Honorable. Can you hear me?
Okay. Let's put him on. Let's put him on. There you are.
Good morning. Can you hear me? Good morning. Can you hear me? 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 Morning. Hello? Hello? Hello?
Okay. Okay. Okay.
There is an echo.
You have to be patient with technology.
Can somebody put my presentation from there? Maybe it will be easier.
Just hold on.
Hello?
Are you doing something about it? Okay.
Do you have my presentation? Can you project it, please?
Well, this is good. The room is filling up, so people are really interested in this particular topic. But these meetings that are organized by ICASA are real important platforms for the Africa region to discuss and prompt each other on the way forward on various matters. No, we can't hear you. Dr. Fall, just wait a bit. Can you hear us? Can you raise your
I
arm
can hear
if
you,
you can hear us? Can you raise your arm? Yeah. You can hear us, but we can't hear you.
Oh,
yeah, okay. Just be patient. Just be patient. Just be. Uh-oh. 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 Well, meanwhile, can we hear a few comments on what Linda has said so that we don't lose momentum? Any questions to Linda? Any comments on what she's delivered? Very interesting issues still raised up about how to manage domestic financing and good examples in various countries. Yes, can somebody come and give the mic to Professor Morenike who wants to comment? Where are you guys? Can you come and give the mic to speakers here? Okay, let me do it. Yeah, go on. There's another one there.
It's not working. Yeah, thank you. Yeah, thank you, Linda, for raising those brilliant issues and a lot around social contracting. But when I sat down there and I was listening, I think it's right that we're advocating around social contracting as a way of engaging the community. But you also noted that we have to raise funding to support this. And my head goes that where's going to be this funding when everything is contracting and the needs is increasing? And it seems to me the one way that the governments are going to take out of this lazily is increasing the tax for the people. We're already seeing it in UK. The cheapest way to get out of this contracting is taxing us. And that's tough. What are your thoughts on this? How do we fund the social contracting route for engaging community people? Thank you.
Yes.
Okay. Another comment?
Yes, please.
Yes, Prof.
Yes, my name is Sam Kware. I'm from Uganda. I was the, I was the program manager of the first AIDS control program. At that time, actually, there was no money, there was no drug. All that we had was the goodwill of our people and also their energies. So the point I would like to say here is that the bulk of the activities, the bulk of the resources for taking care of anybody starts with the individual. First at the household, then at the community level, and then from there the government or someone else can take over, goes with the money. But where there is no drug, where we are lacking resources, I think the issue of community mobilization, community engagement gives you more money than anything else. Those of you who know that if you are passing through a point and you just go through like that, goodwill, to just go through like that, is more than money. So I thought perhaps
Thank you very much. I'm Godson from Togo, the presiding bishop of the Methodist Church. I would like to congratulate the presenter, and I would like to make emphasis on the fact that health issues are obligation of the state, of the government. And it is very important to tell to our government to be responsible of the health of the population. So I want to make emphasis on that.
Emphasis.
I'm Canon Professor Gideon Byamugisha from Uganda, representing the International Network of Religious Leaders living with HIV or personally affected, and here at the courtesy of World Council of Churches. Linda talked about the declining resources. I want to provoke her to think whether it is the declining resources or it's the will behind giving the resources, and investigating how Global Fund can initiate partnerships and collaborations with the Vatican, World Council of Churches, the World Interfaith Movement, to recover, because the biggest issue now that HIV is now concentrated in the most stigmatized community groups. So instead of giving them love, many countries criminalize instead. And we in the faith sector sometimes are not sure of how to handle that. So if the statistics are saying men having sex with men, commercial sex workers, injecting drug use, adolescent girls, these are difficult subjects for legislators who are not love competent or love resilient to allocate finances on. So I would really urge that we see how to integrate spirituality and morality within the financing agenda.
Linda, that's an important question in terms of how you manage key populations and how they are stigmatized and therefore how they may fail getting financing. Any other comment before you come in?
Yeah, good morning. My name is Richard Msitu from Tanzania. Thank you. I would like to thank presenters, specifically Linda. I want to reiterate some few points with the experience from Tanzania, especially on the social contracting, as well as overall domestic resource mobilization. as ICASA, as part of Compass and NSA Health, we have been doing domestic resource mobilization with the government, and we have seen that at the beginning it was a bit difficult to do a thorough advocacy without having the government people from various ministries as far as HIV is integrated. But later on, we have seen that the Ministry of Finance joined on board, and they were passing, in the previous budget, they passed the Finance Act, which rose the ATF funding for HIV by almost 400%. It was like 1.8 Tanzanian shillings billion to 5 Tanzanian shilling billion. But talking of the insurance, the community has to be at the center stage because, as Prof said, the people are the one who has to contribute so that you can have a domestic resource mobilization to finance social contracting. So in Tanzania, through Global Fund, actually, of course, there is a declining funding. We have seen initiative to strengthening community systems. And one of it is making sure that the communities are aware and the communities are part of the domestic resource mobilization. So this is very important. However, with the declining funding from global level, I was kind of triggering thinking to Linda on how are we moving forward from the shrinking funding to how are we going to cover the gaps of community system strengthening so that we can increase domestic.
And then we take it from there.
Thank you so much. So the first question was about the funding and the potential to have, my team is around me and supporting me. Thanks, please. So the first question was about where would those resources come from? Does that mean that we will be taxed as taxpayers? Does it mean it will increase? Now, first of all, one of the things that I was trying to highlight in the presentation is the diversification of that funding. Earmarked. Otherwise, if we are saying that maybe it may happen and we will find resources, if it's not targeted and earmarked, it's not going to happen. That's why we're saying again, in terms of the civil society, there has to be a conducive, safe environment for civil society to operate. They have to have the capacity as well in terms of the participating in the budget process, as well as making sure that those resources are going to the communities. So that is one area that we need to continuously advocate for. The second, please, in terms of the obligations of the state, definitely the health of the people in each country depends on the resources that are mobilized by the state, and the obligation comes from the state. It does not come from the communities. However, the communities are part of that solution. The communities know the issues in their areas, and they can then influence and be part of the solution. declining resources, that's the reality. In terms of the fact that one, the donor countries are having different priorities. So it's changing. It's no longer HIV, TB, and malaria. It's many other things. When we walk into the offices of the donor countries, we start to discuss the resource mobilization. They first talk about the pandemics, they talk about impact of climate change and many other things. Then they talk about HIV at some stage. And the meeting is about resources for HIV, but they are worried about other things. So that they also are worried about their national issues and priorities. So there's competition there. So that is the reality we are facing. So there's both the declining, the competing priorities, and the ODA is not increasing, it is decreasing. Private sector, therefore, has a role to play, and we need to begin to really mobilize the private sector. In the Global Fund experience, for instance, the private sector really came to the table, and we ended up getting more resources from the private sector as well. So we have to think about that and how to mobilize those resources. Domestic resource mobilization and also ensuring that communities are part of the conversation. We need communities not only to call for 15% Abuja declaration, but to really understand the fiscal space, the revenue, and also how much does the country have, and therefore how much is allocated to health. If we as communities go to have a conversation with the health minister only, we are missing the point. We need to have a conversation with the finance ministry as well as the health ministry, so that we make thank you, so that we make an economic point about investing in health is investing in the wealth of the country, and therefore it needs our advocacy as communities. We cannot have a discussion with the Ministry of Health only. We need to have a discussion with all the role players, and we need to stay in the room, because going to do advocacy on the budget speech day, it's way too late. We have to have the conversation, the planning and prioritization earlier on. And that is quite important. I don't know if I have missed any other. I have my colleagues in the room if there's something that I've missed. Yes. So again, in terms of the resource mobilization and making sure that everyone is engaged, the faith-led organization are an important component and stakeholder. Even in terms of organizing that, we will have a discussion, and we've been working with particularly the World Council of Churches to make sure that all our faith-led organizations are understanding the issues around budgeting, understanding the issues around resource mobilization, but also supporting the communities to engage, to participate, and be part of the service delivery.
I think it's clear the state has the responsibility for the health of the nation overall. It is up to us, it is up to the state to create that environment where all these players can contribute, including church-based organizations, the private sector, partners and donors. And indeed, the state is the one that stimulates taxes and appropriate taxes that go to the health sector. But working with the Ministry of Finance is key. There's no way you cannot work with the Ministry of Finance. And in the past, people were having summits and meetings with the ministers of health, leaving out the ministers of finance. And that did not make sense, because as soon as you're Minister of Health and you go back to your country, you still have to tackle the Minister of Finance. So it's better to get them right at the base. Our time is actually running short without us seeing the other. Is he ready?
I'm ready. Presentation?
Huh?
My question.
Dr. Fall, no. There was another presenter who was supposed to come. But I don't think we have time for that, so we can have contributions now.
All right, thank you very much. My name is Martin Mary. I served as a program manager under the Global Fund project in Nigeria. And I think when we have opportunities like this, we need to commend the communities. They are already, taking care of a number of domestic resource mobilization is already happening in Nigeria, while we have a lot of communities where even the communities are now building more health centers, procuring consumables even for the health systems to ensure that we have more access for people in the community. So when power to the to strengthen these people at the community level. Thank you.
Dr. Ford.
Yes, please. Honorable Minister, can you hear me?
Can you hear him? Can you hear him?
Hello? Can you hear me? Yes. Can you hear me? Okay. We can proceed? Okay, thank you so much. Thank you so much. Thank your colleagues. It's a great pleasure to be with you today. And when I was invited, when I look at the title of the topic, it was about domestic financing for research. I asked myself, are researchers thinking that they can get financing without domestic financing in health? So that's why you see the title, Domestic Financing for Health and Research in Africa. Next. And this is the next slide. Yeah, really important to highlight the burden of disease and the low investment in health in general. And the even, worst case for research. The investment in health is already low, but looking at, Africa only representing 2% of biomedical research, the situation is even worse. But most of the time, the scientists are disconnected from the society and disconnected with government. They talk to themselves. When we publish paper on the Lancet, on the New England Journal, who will read them is mainly scientists. So when we talk to ourselves, we miss opportunities for financing. We need to tell to our, governments that there is no development without health, and there is no health sovereignty without research and innovation, including R&D. Next slide. And we have seen the devastating impact of COVID-19 in our society. If you compare it to HIV, TB, and malaria or anything else, there is no comparison. And we need to keep reminding our, politicians that there is no prosperity without health, and any health crisis can have long-term impact in our society and economy. Next, just to show the disease burden, the next slide. And the first slide is about the HIV burden. I will not take time here because you are all familiar with it. If you go to the next slide, we talk about the TB burden. And the next slide, again, is about TB. You can see in Africa where we have HIV, of course. And this next one is about, hypertension and cardiovascular diseases. This means that in Africa, we are, facing so many diseases, non-communicable diseases, communicable diseases, but also outbreak-prone diseases I didn't present here. But the issue is we cannot deal with the disease one by one in terms of public health program and impact. And I will come back to that next. And we have critical gaps.
I'm so sorry. I think we'll have to find another time for him because there's another program that is to come now. I really apologize to all of you, but there we are. Dr. Fall is still speaking, but we cannot continue. Sorry, but Linda, let me thank you. You still want to comment? Let me thank you. You have been there, and domestic finance mobilization has been emphasized, and it is clear that we are now our own domestic financiers. And what Linda was saying essentially was how do we raise that, and what are the mechanisms of ensuring that it is transparent, that it is usable, that it is sustainable. And I think that was those were very good points for us. Thank you so much, and thank you, audience, for listening. Thank you, Dr. Fall, for not falling, but just hearing that the time is gone. Sorry. Okay. I'm going to call upon the next presenters to come onto the platform.
Good morning, colleagues. It's unfortunate the plenary session had to be cut. My name is Emela Samode, and I'll be your coordinator for this plenary hall during this ICASA. Now, if you look at your program, there's supposed to be a high-level OFLAD meeting here. This meeting has been moved to the presidency, and some of us have been invited to participate at the presidency. But my understanding is that that session will be transmitted onto this screen. So we will still have the opportunity to participate virtually in the OFLAD meeting. So please, those of us who are interested in the OFLAD meeting, you can still stay in this plenary hall till that session is beamed to us. So we'll see how the technology goes. So please bear with us. If we realize that this is not going to come off, then the next session in this room will be exactly at 13:00. That's 1 o'clock. And that will be an abstract-driven session entitled Drug Development and Resistance. So that is what we have for you this morning. The OFLAD meeting will be at the presidency. It will be beamed here if the technology works. Otherwise, the next session in this plenary hall will be at 13:00 hours, and that will be on drug resistance. Thank you very much. And as I said, please, you can wait for the OFLAD meeting. You have something? Which session is that?
This is Africa Treatment Access Partnership on 8th.
Well, I just got the instruction. So
Oh, really?
if it doesn't, you guys are ready?
Yes, we are very ready. We are over there.
Well, the technology doesn't work. My instructions are that the OFLAD meeting will be beamed here. So what are you guys supposed to start?
At 10:15, this is the time that we're given. I don't know. Maybe there's a mix-up.
Let me see the title of your session. Let me see the title of your session.
We don't have it in here. It was a replacement of yesterday's. So
Ah.
it was, yes. But I could get in touch with the person.
No, but if you are really ready, I can. And then I'll hand over to your thing.
You sure?
Yes, let me give you the title of the session.
Okay. Please give us 5 minutes and we'll tell you whether the offline meeting will be beamed here or we'll have another session in a couple of minutes. We are trying to sort out the technology. So please bear with